Hello, here we are to talk about the maximum intercuspation in dentistry. Okay, so what is the meaning of maximum intercuspation and what kind of information we can extract from maximum intercuspation in our cases when we're going to do diagnosis and we will proceed any kind of treatment? Can be either prosto, ortho, or any other specialty in dentistry. Even a simple restoration or everything, usually we are trained since our graduation to maintain and to continue the maximal intercuspation of our patients. So when the patient comes with a certain problem, we look into the teeth, ask the patient to open the mouth and close, and we start the treatment from that position. Okay, so that position is usually called as maximum intercuspation. Okay, here comes a point. What is the information that we can extract from that position? Okay, so if I take this pair of models here on my hands, this is a very, very common situation I receive, and I usually, my students come to me with cases and ask me questions. Hey, doctor, can you help me to treat this case here? And they give me a pair of models like this, exactly like this. And they want my suggestions, they want my advice to treat cases just showing the situation of the patient like this. So this information from the model like that can be sometimes useful, but sometimes not. So at this moment, I am directing this speech or this conversation a little bit more to the doctors, a little bit more directly to doctors. But if you are a patient and you also want to learn something about that, to even select better your professional that's going to take care of you, the practitioner going to treat your case. This is a very interesting information as well. But this is a little bit deeper conversation. Sometimes you not understand everything, but hopefully you can extract some nice things for good selection of your doctor. So let's get back to the main topic, which is the relevance of maximum intercuspation in dentistry. So when the doctor or the student come to me and ask for advice with models like this, what is the importance? What kind of information I can extract to give a nice advice for my student? When I look here, usually I am orthodontist, so we orthodontists are trained to look occlusion from outside. I can see here some stuff. Let's say, oh, I can see molars class 1. I can see a relation of occlusion 2 to 1. I can see canines in nice position. Oh, the midline match. Oh, I can see here the overjet overbite, not so bad. The other side, almost cross bite here, molar. So from now on, what else? Here comes another point. If I start based on this maximum intercuspation, this is habitual bite. This is the position in where the patient feels at this moment comfortable. Or this is the position in where when the patient closes, maximum contact will happen. This is kind of a system to keep the patient alive. So the more teeth I have in contact, I can chew better, I can feed myself better, and I can keep my life better. But in terms of treatment, okay, the patient come to you with certain chief complaints, or the patient's not happy with the smile, or sometimes I don't like my crooked teeth, I don't like something, and I start to treat based on this position. What kind of mistakes can I commit? Here comes another point. Question number 1, where are the condyles in this situation? Where are the mandibular condyles inside glenoid when I look this situation? Another point is we have to understand that to get the maximum intercuspation, the patient will close the mandible. So the mandible will rotate in a closed way until you find a final position of the teeth in maximum intercuspation. This will mean that the first contact will happen The patient might have one first contact in the molar, for example, or bicuspid, doesn't matter, or incisors, doesn't matter. After this first contact, the mandible will slide to another position that will find a second contact, a third contact, and stop in a position that we call maximum intercuspation. That position means that the patient can stay with all teeth in maximum contact. Sometimes I have an open bite, sometimes I can have a deep bite, sometimes I can have class 2 one side, class 1 the other side. So it can be many ways. Class 3, class 2, doesn't matter. If I start to treat based on this position, I can commit a very serious mistake, which is where are condyles? So when I look models like this, or now, super fashion, look models in scan, like you see in my screen. I can just grab my mouse and rotate, and I show my patient, look at this, look at that, look at the overjet, look at this, I can rotate. It's so fashion, so good. Look, it's so nice, I can rotate. But what is the difference between what I see here on the screen and what I see here? Zero. The difference absolutely zero. The advantage for my office become not full of plaster. Okay, I don't need space to store my models physically. Here is basically digital, so I have my data bank here, and I have my patients stored in a cloud. Okay, and I can rotate and I see contacts, but I still have a problem here. This is a 2D screen with a 3D image inside. Here, if I want to feel, it's really much better. Okay, the old style impression with alginate and pouring plaster and so on. It's really much better in terms of diagnosis than just looking to the screen. But both of them, they have exactly the same problem. This is a maximum intercuspation, and this is also a maximum intercuspation. Okay? No matter if it's look fashion or old style, the information is exactly the same. So, oh, professor, what kind of thing I need if I cannot use this, if I can't extract information from models like this? So, what should I do? So, here comes another point. I need references. So, first of all, I need a reference plane to locate the condyles in the space. And mandible contain the teeth, the lower teeth. Maxilla contain the upper teeth. Maxilla, I cannot move. It's fixed into the skull. Mandible is movable through the joint, to the TMJ. Okay? So this movement, translation, rotation, side to side, forward, back, closing, opening, doesn't matter. This movement happens through the joint, but end up with teeth in contact. Okay? So when I chew, when I move, when I go clenching, when I go bruxism, and anything I do with the teeth in contact, I will depend on the interferences that the upper and the lower teeth will find during this closing process of the mandible. So the closing process of the mandible is very, very important to my diagnosis. So I need to understand in where the condyles are located when I have maximum intercuspation. Sometimes the maximum intercuspation can make one condyle moves backward or upward, and another condyle moves forward and downward, for example. Never forget that the mandible shape is like a horseshoe, okay? So the horseshoe is moving, and one side moves, the other side automatically will respond to this movement. So it's impossible to move one side only, the other side always will also move, okay? This way, I need to have a system during my diagnosis that I can understand the maximum intercuspation in condyles location together. I cannot just treat and align the teeth based on the simple maximum intercuspation. This is a very poor information. Very, very poor. Sometimes I have a condyle backward and upward and the disc displaced, and I will align and maintain the mandible in that position. So imagine if I am treating a young kid with 9, 10, 12 years old, and I will keep the mandible in a bad position throughout this little patient's life. Imagine in 12 years, maybe nothing happened, but in 2 years, 3 years, 4, 5, 10 years, the patient starts to have problems. And TMDs can appear, okay? Disc dislocation, clicks, lock joints, pain, everything, because the orthodontic treatment did years ago didn't take in consideration the position of the jaws. I understand completely that we can adapt, okay, during the growth. Some patients can adapt, but some patients cannot. And my focus is exactly on those patients. So if the patients can adapt, and I understand that, it's much better if I position the mandible and center the condyles in the fossa. So I have much better chances for adaptation if the mandible is backward and under compression towards to the skull. So sometimes I hear from some doctors, hey, but it's not a problem. The patient can adapt. Okay, I know, but adaptation sometimes not a good word. Sometimes adaptation can be very bad. Okay, and condyle can resorb, and we can have arthrotic joints. We can have so many problems that comes just because we align the teeth based on maximum intercuspation. So what should I do? Oh my God, how can I make a good diagnosis for location of the joint, the condyles in the joint? I need to find a way with instrumentation and images to be 100% sure in where are the condyles in different positions. Maximum intercuspation is just one position, okay? I can go with my patient to reference position or CR position, depending the way you want to call that position. I would say most posterior without straining any structure, okay? No compression of any structure. So condyles lie back and stay in unstrained position. This is what we call RP, with no teeth contact. So I understand that if I have a GPS here, the condyle in the most posterior, no strain position dictated by the ligaments and muscles, this position will be my point 0 on my GPS. And from this position, I can move anywhere I want. But this is the position of the condyle AP. But what about the position of the condyle to the skull? So I need another reference. So I know in my GPS the location of my car, for example, is here, but I don't know if my car is facing to the north or to the south or to the east or to the west. So I need another reference, which is physical reference to the skull. So for that reference, I need instrumentation. Otherwise, I cannot locate in my GPS in where are my condyles. So the patient's condyles needs to move from 0 position to somewhere, which will be my therapeutic position, my treatment position. So I like to use this instrument, which is articulator, okay? With the articulator, I can mount the case. I can see the case in Super 3D, as you see here on the screen, okay? We can also use articulators on the screen, no problem. We can also have articulators there. But it demands another process of mounting, which takes, for me, much more time than working with physical mechanical articulators like this. They are adjustable articulators. They can be adjustable as well in the screen, no problem. But I prefer to have this. This is my personal opinion. But we have, okay, available softwares that can gives you a 3D vision with articulators on the screen as well. So, okay, Now I have what? The position of the models referred to condyle most posterior, which is RP position or centric relation. And another way is to get my skull reference. You can use a face bow, okay? The face bow will take you to a skeletal position, which is Frankfurt, okay? Normally Frankfurt. But to be more precise, we usually use more modern way, which is locating the axis of the condyle to orbita. So we take a functional reference. So I use my condyles as my starting point reference. So I know the condyle is most backward, plus this is the axis we call hinge axis. And from here I can start the movement anywhere I want based on orbita, which is my skeletal point. So now I have a plane, okay? And I have a physical plane like this from condyle hinge, skeletal point, and I can move the mandible towards down, forward, left, and right, and so on. To identify precisely that position, I use another instrument, which is called condylography, or axiography for the doctors who knows the system for a little bit in the past. So this way I can locate 3D way the patient on space in RP position, mounting mandible maxilla in according to the axis orbita plane. Okay, from here I can move anywhere I want. So this RP position is my position 0 because in here I know where are condyles. It's completely different than take the models on my hand like this. Where are the condyles here? I have no clue. 0. No clue. I cannot even guess. Okay? If I add to the instrumentation images, imagine now I add tomographies, I had COMB-CT, I will see in different positions, even if this is in maximum intercuspation or the position you want to create, where are location of the condyles. Plus, in CBCT, I only see the bones, but if I want to see the disc, if I want to see ligaments, muscles, I can ask for an MRI. A magnetic resonance gives us a lot of information about the disc. Where are the discs? If I have disc displacement anteriorly, medially, laterally, or even posterior, is a very important information to move the mandible in this space and to get a new mandible position during this therapeutic position to treat my case. So when I plan this position, I am 100% sure that the patient has the disc on top of the condyle. The condyle is in exactly center of the joint, and all the muscles are calm in that position, giving us 100% sure that I can now move the teeth towards to maintain that position. Oh, if I use prosto or ortho or anything else, just a simple restoration, doesn't matter. This is for any case that moving the mandible is my objective during the treatment. So, as an advice, to finish our debate here, our conversation, don't take maximum intercuspation as your starting point for prosto or orthodontics, okay? Because if you come here with this position, you have no idea where are condyles. How is the mandible in this space? Sometimes the midline doesn't show you exactly that the mandible is shifted or not. Many times we have dental compensations here that will masquerade a bad mandible in the space. So go towards to a deep understanding of your patient problem. If you want to do good for your patients, if you want to really be a great doctor, take in consideration the joint together to the occlusion. Otherwise, you will not give to your patient a chance to finish the treatment in a health joints. Hope this little hint help you in your office a little bit, but you can come to me and say, oh, professor, I never learn. I have no idea. How can I do it? Nobody told me in graduation. I came from my university, and no professors told me how to use the articulator and so on. Okay, I understand. The curriculum now is very, very poor. The graduation courses the dentistries are now lacking the diagnosis of the joint, and this should be maybe taught in the first year of your graduation, but unfortunately, things are moving like that. So little by little, diagnosis becomes secondary, and our specialty dentistry become more cosmetic, which is very sad because we are doctors of mouth, neck, and shoulder, and head, and everything. Okay, so if you want to learn this, you can go to my website www.cbom.com.br. Okay, www.cbon.com.br as Brazil. Okay, and you can follow my future courses, and I am always teaching many places. Sometimes I am University of Illinois in Chicago. Sometimes I go to Europe in Vienna. Sometimes I teach in Vietnam, in Philippines, Mexico, Guatemala, Colombia. So I travel, and you can follow me. So maybe I am close to your place, and you can just register yourself and learn a little bit more about this concept, and you can do much better to your office and much better to your patients. I'm sure everybody wants to treat patients in full, and this is the great opportunity to learn functionally how to diagnose and treat your cases. Hope you enjoyed that. Click here in my YouTube channel so you can follow my videos. Every time I upload a new thing, you guys can receive in the first moment that I have now launched a new video. I am planning to do this every month, at least one or two new videos. You can also subscribe here to my channel, press the like, so it means for Google that you enjoy my work. And if you have questions, just type here, write down here, and certainly we will interchange, and I will communicate to you. Uh, Hope you enjoy, and see you on my next videos.